Good afternoon, everyone. If you could just bow our heads in a word of prayer, please. Heavenly Father, we thank you for this gathering here tonight as we of the Caribbean Regional Midwives Association explore avenues and learning opportunities for our members. We ask, O Lord, that you be with us as we proceed with this afternoon's webinar. We know that you and you alone give grace and glory. We also know that no good thing will you withhold from us if we walk uprightly. So, Father, Lord, we ask you to put your blessings on this webinar this afternoon. Bless the speakers, O Lord, and give them clarity so that we can understand what is spoken about tonight. This we ask in no other name but yours. Amen.
Amen. Amen. Thank you so much, Miss Rollock. And at this time, we are going to move into our welcome. Our president, Mrs. Devery Stewart, is going to make you all feel welcome at this time. Mrs. Stewart, over to you.
Thank you so much, Madam Chair. Good night, everyone. Good evening. Welcome all to the platform. I should say Happy New Year to you, and hope you've had a great start to the new year. Tonight, as we are having our very first webinar for the year, I invite you all to listen and reflect on such a topic at this time as we speak to perinatal health and how the implications for midwifery practice antenatally in the labor ward and afterwards, and to see how we can learn from these to improve the care we give in our countries, to our women, and to our families by extension. I trust you all will have a great time. And for those of you, I must add quickly, who are not members of your local midwives association, to reach out to your local association and join and be a part of this great group in the region where we learn together throughout the year. Thank you so much. And Madam Chair, over to you.
Thank you so much, President Stewart. Okay, so tonight, as I said earlier, that our topic is perinatal care, identifying the risks, preserving, protecting, and enhancing neonatal outcomes. Tonight, our this session is going to be dealt with in two. All right, so for tonight, we're going to look at risk assessment and clinical care. And this is going to be done by Dr. Shirley Curtis. And the next session will be legal and ethical aspects of midwifery, which is going to be done by Mrs. Natasha Robinson. So at this time, I'm going to invite Mrs. Curtis. Now, Dr. Curtis, she's a registered nurse, a registered midwife in the Commonwealth of Bahamas. She did her basic training in the Bahamas, the Bachelor of Science in Nursing Education University at the University of the West Indies, Mona, Jamaica. She attained her master's in perinatal nursing at the University of Pennsylvania and her PhD at the University of Miami with emphasis on health and empowerment to adolescent pregnancy. She recently retired as an associate professor at the University of Bahamas School of Nursing, now adjunct faculty, where she coordinated the midwifery post-basic program. She also lectured in various courses in the generic BSN program for registered nurses. Dr. Curtis is now a helping babies breathe instructor and a master teacher in competency-based education. She is a founding member and treasurer of the Midwives Association of the Commonwealth of Bahamas, and also a founding member and past president of Caribbean Regional Midwives Association. She has been a registered nurse for 43 years and a midwife for 36 years, and also an educator for 32 years. She's a co-founder of Phoebe Birthing Center Limited, Natural Birth Solution. She has chosen this profession. She had many options, but never regretted the choice. And to Dr. Curtis, it's a calling. At this time, it is with great pleasure that I ask Dr. Shirley Curtis to go ahead and do her presentation at this time. Dr. Curtis, over to you.
Good evening, everyone. Good evening, everyone. It's so good to see you. I echo the president as she welcomed you into 2026. And it is my pleasure to present. As past president, I always try to not to be on this side of the presentations, but I think I've run long enough. When they started talking about risk assessments, this is one of the areas with my master's degree, which is perinatal nursing, which covers more high risk maternity. So I love this area of midwifery. Before I get started, I hadn't had a chance to look in the chat, but I hope persons in the group have put which countries they are coming from, so that we can know the persons represented. Now, before I begin, I should have actually done a poll question to find out, and you can type it in the chat for me. The countries that actually use the perinatal clinical record from PAHO, called the SIP form. If your country uses, I know the Bahamas does, so the Bahamas, you don't have to put it. But from any other country that actually use the SIP form as your form of record keeping for antenatal, postnatal, and intrapartum care, if for those persons that actually use it across the board, or if you only use it in one area, like if you only use it for antenatal, or if you only use it for labor, just type that in the chat for me. I'll look at it afterwards. I'm just interested to know how many persons actually use it. In the Bahamas, we do use the perinatal record sheet. And so it is really helpful in identifying your risks. So the Education Committee asked us to talk about identifying risk and preserving and protecting and enhancing perinatal outcomes. And the objectives, basically was to identify key maternal, fetal, intrapartum, and systemic risk factors, outline the continuous assessment in midwifery practice to reduce adverse perinatal outcomes, and to describe and apply evidence-based perinatal management practices. And as I looked at those objectives, which are very comprehensive, one of the things we have to talk about is the concept of what is the perinatal period. And basically, clinically, it is the period from fetal viability to 28 weeks after the birth of the infant. That's clinically, but practically, it covers a time from 1 year prior to conception to 12 months after the birth of the child. So when you talk about that perinatal period, if it's going to be clinically effective, you have to start prior to conception. And then, of course, risk assessment. The risk assessment involves identifying and mitigating hazards to ensure the health of the woman and the child and her family. So it goes beyond just the mother. Now, risk assessment is not a one-time process. All right. I know we have a habit that we identify somebody as high risk and they remain high risk throughout the pregnancy, whether you mitigated the issue or not. If they're low risk, these patients tend to move from low risk, and then you identify things as the pregnancy go along, and then they might move into intermediate or high risk. So it's not a one-time process. This is done at every encounter. When you do a risk assessment, it's at every encounter with the woman from preconception throughout the pregnancy and postnatal. So you could have a woman that was low risk throughout her pregnancy and becomes high risk in the postpartum period. So the risk, it's very fluid, right? It is vital that the care is thorough and individualized. So every patient that you see every time, it's a thorough, individualized care. Minor disorders can be just as hazardous as major diseases if they are not managed by the client and her healthcare provider, right? So that those minor disorders then can become major disorders if they're not properly managed. Most women and infants suffering morbidity and mortality are usually from the category of women that are classified as high risk. And note the word usually. You still have a percentage of women who are in that low risk who become high risk in a very short period of time, who end up with morbidity and mortality. But for the most part, you find that it's the high risk clients. So we said that perinatal care starts from preconception care. And the optimum time to assess, manage, and treat many of the conditions and complications, it's before pregnancy occurs, right? So the first prenatal assessment should be given when the woman is, okay, thank you. So the first prenatal assessment should be given when the woman is considering pregnancy. Now, a lot of times, one of the questions on the SIP form, is, was the pregnancy planned? And 75% of the time, the answer is no. That's from my experience. There are about 25% of persons, they actually, okay, I set out to be pregnant, I plan to be pregnant, and I have ticked all the boxes to get to that particular point. For the most part, some persons just decide to get pregnant, but they haven't done the work to get pregnant. Oh, they decided, but they haven't done the work. So they would consider that a planned pregnancy. All right. But anyway, so when you're in the preconception period, you're going to find that the same things that we do at that first visit when we see the client should have been done in preconception. So getting that detailed history, family history, medical history, surgical history, drug histories, right? Doing the basic physical assessment and laboratory evaluations, including sexually transmitted infection screening, right? So it gives time to get a full history, because sometimes you would ask a patient on their first antenatal visit about family history, and they don't know. Do you have anybody in your family that had seizures? Do you have anybody in your family that has diabetes? And they don't know, right? But I only know on my mother's side. I don't know but nothing but my daddy's side. And so if you do it preconception, it gives time for, if they have access to their persons, to go home and ask their mothers some questions, right? And so you get a better picture of the actual history, family history of the client themselves. Even the partner, what do you know about the partner's family? All of that gives you time to get information, right? So you get a full family history, and then you have time to draw rubella titers, and to immunize susceptible clients and to provide contraception if you had to give immunization because the titers were low, things like that. These are things that should have done preconception, but we find that in most cases, we don't see the client in this preconception phase, right? Most times, we don't see them in this preconception phase. There's something across my screen that I need to move, sorry. Okay, so, all right. You screen appropriate for appropriate genetic populations, and you have the time in preconception to screen both parents, right? And when we talk about genetics, for us, the major thing as a Black population, it's sickle cell disease, right? But now we have a mixed population. Our population is not just coming from the Black population. So now we have to, that's why that family history becomes so important, because we are intermarrying, right? And so you get the appropriate genetic screening for the individuals, and then you do pre-pregnancy counseling and education so they know the risks, right? You treat pre-existing conditions, sometimes weight reduction, sometimes medical adjustments, education on diet, exercise, occupational hazards. Sometimes it might require persons making some appropriate adjustments based on their history. Being to begin your prenatal vitamins and your folic acid. We know that the giving of folic acid is really only effective in that first trimester. But if you're seeing the client almost to the end of the first trimester to the beginning of the second trimester, sometimes by the time the client stroll into antenatal clinic, you're already behind the 8 ball with the folic acid, right? Reduction and cessation of harmful social habits, like having multiple social partners, sexual partners, smoking, drinking, right? So reduction of harmful social habits. Gestational age dating. So you start paying attention to your periods. Are your periods regular? Do you know when the first day of your last menstrual period was? So these things, these are preconception things. So you're planning to become pregnant. So you're gonna pay attention to these things. And then for persons who have real medical or even social issues, you start that joint management from preconception. But that's the ideal, right? That's the ideal. Why isn't my screen moving? There we go. So as we know it, for the most part, risk assessment starts at that prenatal visit, right? That's what we call the history taking, right? What we call the booking visit, when we book the client. And so that initial antenatal visit, normally this is the first contact, right? That's the ideally we would want it done in the first trimester, right? Because of the critical perinatal outcomes. Approximately 3% of the live-born infants have a major congenital anomaly. It occurs from the first trimester, that critical period. Half of the anomalies that you see will be present at birth. Sometimes the patients don't even go to term because of anomalies that occur in that first trimester, right? And then the remainder of the persons, anomalies sometimes become evident later in childhood. So anomalies that occur in that first trimester is not always apparent at birth, right? Not all of the relevant information required is always found on your perinatal form. So when you are taking your history, you have to be thorough in taking your history. So things, the study of, when we talk about teratology, right? This is the study of abnormal development and is directed at causes of mild formation or mild development of the fetus. And a teratogen can be any substance, organism, of physical agent capable of causing abnormal development and can cause anomalies in structure, function, and growth, and in growth retardation and death. So when you are taking the history of the client, you are looking for things, any teratogens that can cause issues within the development of the fetus. And those perinatal forms sometimes do not reflect it. Things like, do you have pets at home? What type of pets do you have at home? Who's responsible for the cat and the cat litter? And all of those things that can actually cause. And nowadays we've become quite exotic. We have things like birds as pets. And so we have to pay attention to those things that can actually cause conditions that normally would not affect humans, but it has a mild, causes abnormal development for your fetus. Right? So one of in taking your history, the social and demographic risks. So things like extreme maternal age, we all know that, but what about the age of the father? That also has an effect on the outcome of the fetus. All right. The socioeconomic status, who is working in the family, do they have a car? How will you get to the hospital when you go into labor? Nobody has a car. Everybody is using public transportation. And so you start putting plans in place. This is socioeconomic risk factors. And so you have to start putting plans in place from the beginning. What about the environment itself that the person is living in? Do you have rodents? Are you using well water? You see, rodents and well water don't go well together, because now you're going to be talking about what? Leptospirosis in that water, right? In the well water. Using well water and having a cesspit, right? So the cesspit can contaminate the water table. That's a risk. So now you have to tell the patients about the use of the water and whether or not the water is filtered, whether or not the water is treated. All of these things are risk assessments that you're doing. Occupational hazards. One of the in some of our countries, we have a lot of industries, right? Even things like farming and dealing with fertilizer, because we have more females getting into those areas as well. So what are those occupational hazards? And so you yourself have to become well versed on what can possibly go wrong as it relates to the occupation of the individual. And of course, we talked about social practices and then nutritional practices. So some persons, they are eating healthy, right? But those in eating healthy, you have to ensure that they are covering all of those trace elements that are required for the development of a newborn, of a fetus, right? So when you have somebody who might be vegan, right, or they don't eat meat, so we have to be sure that their protein sources are of such that they will get what they need for the development. Sometimes it's just, I don't drink milk. I don't want anything. But the baby needs calcium. So how are we going to get calcium to this baby? You see that all of these things, these are risks that you are identifying. The risk is to the mother and to the baby, right? Because I always tell them, you cannot drink milk, but the baby's going to get its calcium. It's just that you are going to end up with osteoporosis at the end of the day. You're going to end up with dental caries and toothaches and everything else that go along with being calcium deprived at the end of the day, because my students don't like me to say it. I say the babies are parasites. They will suck you dry, right? So wherever they can find what they want, they are going to get it. They are going to get it. So it's up to you now to supply enough nutrients so that they get it and you are well at the end of the day. Our medical risks, we know family histories, um, and within the Caribbean, we have our hypertensives, our diabetics, right? You have seizure patients, and then you have the race related, like we talk about the sickle cell disease, but if you have Jewish persons, the Tay-Sachs, and everything else that go along with being in a mixed race society nowadays. So, and the intermarrying. So we have to look at race-related risks, right? And then persons who might have allergies. So you have to do vaginal examinations, and they might be allergic to the very glove that you use. They may be allergic to iodine. So all of these things you have to, and not to mention medications, right? And then you have gynecological risks. So you have to find out the gynecological history, all of their STIs, if they've had any gynecological surgeries. Um, um, One of the things that I found that is with the perinatal form, that the obstetric area, although this is an obstetric area, I find that that area is kind of weak on the form, in that it you have to, it doesn't give you the space within the form to break down each pregnancy. So yes, you're going to know how many pregnancies the patient had. Yes, you're going to know how many stillbirths the patient had. You're going to know how many terminations the patients had. But each pregnancy, break it down. How long was that pregnancy? How did you go into labor? Um, how long was the labor? What was the birth weight of each baby? Because when you do that in sequence, you start to identify risk. So you see this woman, she has a family history of diabetes. She herself has no diabetes, but every birth the baby start is getting bigger and bigger and bigger. You have just identified a risk, right? So when you look at the family, obstetric history, um, how if she's having stillbirths and terminations, and they happen at the same time every pregnancy. If she starts to have premature contractions, preterm labor at the same time every pregnancy, then you can mitigate that. You don't have to wait for her to go into preterm labor before you put that cerclage in, because you know it's coming. Because she's showing you a pattern. And so those obstetric risks, I find that in the perinatal form, you will actually have to, thanks, Marguerite, mute your mic, please, thanks. So you will have to be sure that you take that history, that detailed history. What is the outcome of the baby? How long has she been breastfeeding each pregnancy? And you make sure that you have that information down pat, so that you can now identify and refer in a timely manner, or collaborate in a timely manner. The patient don't have to go into an issue before you start referring. You see a pattern and you collaborate and you start the investigations prior to. The present obstetric history, of course, that last menstrual period is challenging for a lot of our people. But nowadays, I find that the young people are good at it, because they have that down pack in their phone. You say, when was the last menstrual period? They pull out that cell phone right away, because they document everything now. You can almost find it on Facebook, TikTok. Oh, I'm bloated today. This is the first day of my period. I don't want to be bothered. Everything is actually, they document everything. So their social media will tell them. They could go back in their phone, or they have it in their calendars. So I think they are better at it than previous generations. And then sometimes it's cultural too, whether persons are taught to keep track of their periods. And then making sure that you do the proper calculations. Now we have the gestational wheel, but we know we make the students do it by hand, right? And then they learn it by hand, and then they learn to use the gestational wheel. The ultrasound is very important, and that early ultrasound, as it relates to risk, becomes vital. That early, when you're dating, when you are dating, ultrasound should be done before 12 weeks. 12 weeks gestation for dating of the pregnancy. When you start doing ultrasounds after that, yes, the dates are going to change, but you do not change your estimated date based on late ultrasounds. The earlier ultrasounds, if they're done correctly, are the most accurate, right? Anatomical ultrasounds at 24 weeks become very important as you relate to risk. So if you see anomalies in organ development, the earlier you know, the better you can help this patient manage her pregnancy and the perinatal outcome. So you don't end up with surprises at the delivery. Okay? Of course, your physical assessments. And as I said before, this is not a one-time thing. This is an ongoing thing. Yes, you're going to do a very detailed one at the beginning, right? General head to toe, include that pelvic assessment. You have to know what's going on down there. Looking at that cervix. You have to do that speculum exam. Doing pap smears, but we always would want to encourage the patient to have done their pap smear before they became pregnant, right? But the reality is this is the only time we see the woman. So we have to catch them when we see them. So the pap smears are done in early pregnancy, but that should have been done the year before. So you know that the woman have had a clean pap smear within the last 12 months. And of course, getting your baseline vital signs is very important, particularly when you're dealing with hypertension. With hypertension, yes, we look at the raw numbers, but the reality is you have to look at what the woman's baseline vital signs are. And if the woman was not attending doctor before she became pregnant, and the first time you are seeing her is at the end of her first trimester, you have no idea what her baseline is. That's the reality. We will use that first vital sign, and we'll say, okay, this is a baseline, but that's not a baseline. That's a pregnant vital sign. Baseline is an early pregnancy vital sign or a pre-pregnancy vital sign. This is what the woman's blood pressure normally looks like. And then you can then appreciate change from baseline. So baseline is really pre-pregnancy or early pregnancy when you're talking about risk. Because sometimes, we say, oh, 130, 90, or she may be preeclamptic, she may be preeclamptic, but her baseline was actually 125. So 130 is not a preeclamptic blood pressure for her, because that is her baseline blood pressure. Now, when you're going to use absolute, you have to start looking at the mean arterial pressure. The MAP reading will give you better raw data. Okay, now this mean arterial pressure is now going above 100, right? So now she's moving into high risk. The mean arterial pressure is moving above 105. So those numbers is a better indicator if you do not have a baseline on your client. Of course, your anthropometrics, the weight of the patient, and of course the height, giving you your BMI is also going to give you put that patient in a risk category. All right. And then we go to our laboratories. Our laboratory examinations, we know all of our blood that we do for all of the midwives on the group. So there are some tests that are only done at the first initial assessment, and then there are tests that are repeated by 32 weeks, 28 to 32 weeks, depending on the country. But these tests are vital for you to know exactly how to manage the patient. So your blood group, more the rhesus factor, is going to give you issues as relates to the newborn and subsequent pregnancies. And so even though that is not going to make the patient of any to move out of the low risk in the pregnancy, now when you come to the delivery of that patient, to be sure that if there's any bleeding episodes, to make sure that that patient gets Rogram. You know, she comes in spotting during that antenatal period, and the spotting ceased during the antenatal period. You have to keep in mind that this patient is a rhesus negative patient. So now you have to say, hey, doc, if you have to refer, this patient needs Rogram. She's rhesus negative. She had a bleeding episode within the pregnancy, right? So sometimes you have to be sure, like I always say, you have to start from the beginning of the patient's notes every time you see them. You start at the front of the notes. That's where all the labs are. Start at the front, look at them, and then you move to current date. So, oh, she coming bleeding, everybody want to be reactive. Let's go back to the front of the notes. What is her blood type, please? What is her hemoglobin, please? Right? So these are the information that you're going to be collecting. So all of these tests are done on the first pregnancy. Your maternal serum alpha fetoprotein, the MSAFP, are normally done for are not normally done routinely in most countries. I know in the UK and in the United States, if the mother's over 35, it's highly recommended that they get them done. But it depends on the country, whether they are private or public patients, whether or not that might be a routine test, right? So your urine cultures, you're looking for your infections, you're looking for your dipstick for your protein, your glucose, right? All of your STIs are repeated, should be repeated by the end of the second trimester, to ensure that if anything has changed since the first trimester, that it can be diagnosed, treated for the most part, or the appropriate medications given, and to decide the course of action as it relates to the delivery of that newborn, to ensure that we are not and the management of the newborn once the newborn is delivered. So we don't want Group B strep is also a test that is done at term to ensure that we are not dealing with any infections, and it's very easily treated should it become positive at term. Now, Group B strep could be positive anytime during the pregnancy, but we want to make sure it's not positive at term, because that is when it affects the pregnancy most, because this is a protection of your newborn as it comes down the passage, right? So that's why we only do Group B strep at term. So after collecting all of your questions and doing all of your examinations, you can miss something. At the end of your assessment, particularly when you're doing that first risk assessment, you always ask the client if there are any areas that she would like to add. Did I miss out anything? Is there anything you would like to tell me? Right? Because there are times when we have not covered things that are pertinent, and that's what makes it individualized. Because, and sometimes we won't be in a hurry. They say, man, the patients, they won't talk too much. I say, yeah, you have to listen. You have to listen because the patient is trying to tell you something. Yeah, sometimes the patients use the antenatal visit as an outing, but we have to be we have to be mindful, but we still have to listen because sometimes they're trying to tell us something. In the first perinatal records that we had, it didn't have things like alcohol use, smoking, and intimate partner violence. Now, on the most recent perinatal records that we have, they are actually included. And it's not included just once, it's included for every trimester. So within each trimester, you have to ask this woman about her exposure to alcohol, her exposure to smoking, and that's um, actual smoking or secondhand smoke, as well as intimate partner violence, because we know that things change and environments change. And so, and if it's not on your form, this is something that you have to be asking the client on a ongoing basis, or sometimes you have to listen for the cues. So when they're trying to tell you something, you have to listen, right? So is there anything else about you that I should know, right? Sometimes it's about having to attend clinic. Mom, I work in, my boss ain't gonna give me the time off. Is there another time I could come to clinic? Do you all have an afternoon clinic? Is So you have to be listening for the cues, because this is a patient she's telling you that she's going to default. She's telling you, she's not trying to be special. She's telling you, I ain't gonna be able to do that. I can't come here in the morning and wait all day. Um, I can't come to clinic from 7 o'clock in the morning just to get a good number and still don't leave clinic until 11 o'clock. I can't do that. My boss ain't gonna allow that. She's trying to tell you something. She's either gonna be a financial risk, she's gonna be a defaulting risk. What are you going to do to mitigate that circumstance? You have to listen and you have to mitigate, right? Um, so after you found out all your information, then you will classify that patient, and that patient is just classified for that particular day, right? And then as you see the patient throughout the other visits, you determine whether that classification holds or if that classification changes based on what the patient has to say, what you find, what your notes find, what your labs find, what your physical assessment finds. You will then change that risk classification. So as midwives, we can independently manage low-risk mothers, right? But we work collaboratively with the obstetricians and other healthcare professionals with the intermediate and high risk. And I want to stress collaboratively. We are not to just turn those patients over to the obstetricians. We have to work collaboratively with them to ensure that the patients, whereas the doctors, the physicians will ensure that those patients are prescribed the right medications, and they'll see the patients more often, and their visits will change and become
Madam Chair, are you in?
All right, it seems as if we have
Also,
Dr. Curtis is having some issues there. She dropped off. She dropped off. Let us give her a little time. But in the meantime, let me remind us of a few housekeeping. Please to remember to place your name, the name of your country, put it in the chat when you come in. Please to remember that. Also, please be reminded that if you have any questions or comments, please to put it in the chat, and we have at the end we will have a question and answer session. Remember also that our evaluation will be shared at the end of the presentations. Therefore, if it is that you are requiring CME hours, if you are requiring CME hours, then you need to complete the evaluation form in order to receive same. I am noticing that we have what 466 persons we have here tonight, and wow, we have a full house, if I can say. We're having persons from all over. I have been glancing in the chat, and I'm not sure if there is any country that is not represented here online tonight. Of course, I'm seeing Jamaica, I'm seeing Guyana, I'm seeing Trinidad and Tobago, I'm seeing Barbados, I think I'm seeing St. Lucia, I'm seeing them, they're Turks and Caicos, Antigua. The representation here tonight is really, really resounding. And we want to thank you, British Virgin Islands. Beautiful. We really want Grenada. We really want to thank you tonight that you choose to be here with us tonight as we look at perinatal risks. Dr. Curtis, for those persons who are not aware, Dr. Curtis dropped off. We're hoping that she will be back in short order as we're looking tonight at perinatal care, identifying risks, preserving, protecting, and enhancing neonatal outcomes. Our presentation tonight is shared in two, where our immediate past president is presenting on risk assessments and clinical care. And we are being reminded tonight of some of the things that is expected when we have the woman in front of us. Of course, she would have gone through preconception care, and now she is on our antenatal visits. What is expected when we are doing those bookings. Later on, we have Mrs. Robinson, who is going to come with the whole legal and ethical aspect of the care, this wonderful care of midwifery that we offer. Still giving Dr. Curtis.
oh no. Hold on. Thank you, Madam Chair, but Dr. Curtis is busy seeing herself and giving a presentation without us. So as she tries to join us back, I suggest we move on to our next presentation while she sorts out that. Is that okay?
Okay. So thank you so much, Madam President. Until Dr. Curtis resume, let us see how much of our other presentation we can get. And we, as I said, legal and ethical principles as it relates to midwifery care. Tonight, I want to introduce to you Natasha Richardson, who is a distinguished Trinidadian professional whose life reflects resilience, faith, and commitment to service. Her journey, spanning healthcare, law, and public leadership, stands as a powerful example of perseverance guided by purpose. Her dedication to service began in childhood as a member of the Trinidad and Tobago Red Cross Society, where she cultivated the values of compassion and community responsibility. In 2002, she pursued her calling in healthcare by entering the Ministry of School of Nursing at the San Fernando General Hospital, qualifying as a general trained registered nurse. After becoming a licensed registered nurse, she joined the North Central Regional Health Authority in 2005 and served in the Neonatal Intensive Care Unit at the Mount Hope Women's Hospital, where she cared for the most vulnerable newborns with skill and compassion. Ms. Richardson transformed adversity in advancement. She completed studies in health, safety, and environmental management at the University of the West Indies, earned her bachelor's in law from the University of London, and completed the legal practice course in Staffordshire at Staffordshire University. In 2017, she was called to the bar of Trinidad and Tobago, expanding her capacity to serve through the legal profession. She later completed her certificate in midwifery at the San Fernando General Hospital, further uniting her medical and legal practice. Today, Ms. Richardson also serves as a member of the board of directors of the Southwest Regional Health Authority, contributing to strategic leadership and governance within Trinidad and Tobago's healthcare system. Above all, Natasha Richardson's greatest commitment is to God, her family, and the continued service of her country. Her life exemplifies the belief that adversity can be transformed into achievement, and that true leadership is rooted in faith, integrity, and dedication to others. It is my greatest pleasure tonight to introduce to you and ask to come and speak to us now, to present to us now, Miss Natasha Richardson. Miss Richardson, it's over to you.
Pleasant good night to everyone. I would like to begin with acknowledging the leadership team and the organizers of this event, Ms. Devery Stewart, President of the Caribbean Regional Midwives Association, Ms. Diana Henry Ernest, Vice President, and Mrs. Marlo Centil, Chair of the Education Committee. I wish to specially acknowledge Mrs. Katian Elborn, one of Trinidad's Southwest Regional Health Authority acting primary care nurse manager and one of CRMA's public relations officer. Thank you for reaching out to me and inviting me to be a part of this evening's proceedings. And to all of our esteemed participants, thank you for the opportunity to present today. It is indeed a privilege to be a part of this session, and I feel honored to have been given the opportunity to contribute. At this point in time, I would like to share my PowerPoint presentation, which would assist me. So bear with me a minute. Could you all confirm if you are seeing the slides on your screen?
Yes, we are
Yes, we are.
seeing.
We are seeing it.
Okay. Mm. Just hold on a minute, please. Okay, sorry for that. So today, with the aid of this PowerPoint presentation, I will be presenting on legal implications of compromised midwifery care in the Caribbean and how such compromise impacts maternal and neonatal outcome. This topic sits at the intersection of law, ethics, and clinical practice. As litigation awareness grows in our region, it is increasingly important for midwives, healthcare institutions to understand not only how to provide safe care, but how to protect themselves legally while doing so. So by the end of this presentation, we would analyze the legal implications of compromised midwifery care, examine how such care affects maternal and neonatal outcomes, evaluate Caribbean regulatory environment, and propose practical strategies to reduce legal and financial risk while promoting safe, ethical, and high-quality care. So, when looking at midwifery in the Caribbean context, we would see that midwives are central to maternal and newborn health care across the Caribbean. In that, we provide antenatal care, intrapartum care, postnatal services, and often act as a primary point often act as a primary point having a little difficulty, so please forgive me. Yeah, this slide skipping. Are you all hearing me clearly?
Yes,
Yes, we
I
are.
am hearing you clearly.
So
Yes,
just
we are.
having a bit of a difficulty with the connection, so please forgive me.
Go right ahead.
So we are saying that midwives are central to the maternal and newborn healthcare across the Caribbean. we provide antenatal, intrapartum, and postnatal services, often acting as a primary point of contact for pregnant women, laboring women, and women in the postnatal stage. Regionally, maternal health initiatives are supported by the Caribbean Public Health Agency and the Pan American Health Organization, both of which emphasize strengthening skilled birth attendants. This places midwives at the core of achieving Sustainable Development Goal number 3, reducing maternal and neonatal mortality. So when looking at maternal mortality in the Caribbean, according to data from the World Health Organization, the leading cause of maternal mortality includes postpartum hemorrhage, hypertensive disorders, sepsis, and complication of unsafe abortions. Now, many of these deaths are preventable with timely and competent care. When care is delayed, inadequate, or improperly documented, not only do clinical consequences occur, but legal scrutiny often follows. And I want to repeat that point. When care is delayed, inadequate, or improperly documented, not only do clinical consequences occur, but legal scrutiny often follows. So with our neonatal mortality trends, in the Caribbean, neonatal deaths are commonly associated with birth asphyxia, prematurity, and infections. Failure to monitor the stress or escalate care appropriately may result in long-term neurological injury. These cases frequently form the basis of malpractice claims due to lifelong disability and associated financial costs. It is therefore important to look at the legal framework governing midwifery. So what governs how a midwife practice? Well, there is no single legal act that governs midwifery practice worldwide. Midwifery is regulated at the national level. What this means is that each country has its own laws, regulations, professional standards. However, there are international frameworks and organizations that guide and influence national midwifery legislation. Global standing and guiding bodies include the International Confederation of Midwives, ICM, which develops global standards for midwifery education and regulation, defines ICM essential competencies for midwifery practice, provides ethical and professional guidance. Now, this is not a law-making body, but it is highly influential worldwide. Another body is the World Health Organization, which issues global guidelines on maternal and newborn health, publishes recommendations for midwifery-led care, and support countries in developing regulatory frameworks. Therefore, practice in the Caribbean countries is governed by national nursing, midwifery acts, and regulatory council. In Trinidad and Tobago, midwifery practice is governed primarily under the country's nursing laws and regulation rather than a separate standalone midwifery act. And these include the Nurses and Midwives Regulation 2014, the Nursing Personnel Act Chapter 2953, Nursing Personnel Regulations, which set out the legal requirements for midwifery training, registration, and practice. Midwives in Trinidad and Tobago must be registered and licensed by the Nursing Council under the Nurses and Midwives Registration Act and related nursing laws. Other examples in the Caribbean include the Nursing Council of Jamaica and Nursing Council of Barbados. Further to this, most Caribbean jurisdictions operate under common law systems. Therefore, negligence principles are derived from English legal traditions. Therefore, it is safe to say that professional standards are guided both internationally and nationally. The International Confederation of Midwives outlines essential competencies that include accountability, evidence-based practice, and ethical conduct. Failure to meet these standards may result in civil liability, criminal charges in extreme cases, or professional disciplinary action where negligence is noted. So, what then constitutes negligence? To establish negligence, 4 elements must be proven. First, a duty of care existed. Second, that duty was breached. Third, harm occurred. And fourth, the harm was caused by the breach. So, for example, if a midwife fails to recognize fetal distress that a reasonable, competent midwife would have identified, and the baby suffers hypoxic injury, a court will examine whether the standard of care was breached. So, having stated all this foundational information at this point in time, most of you might be asking yourself, well, when does this become relevant in practice? Well, it does with compromised care. So the next question we might be asking ourselves now is, what really is compromised care? Because all we do is go to work and do what we are accustomed doing. So what really am I doing when the day comes that could be considered compromised care? Well, simply put, compromised care refers to care that falls below accepted professional standards and results in actual or potential harm. Again, compromised midwifery care refers to care that falls below accepted professional standards and results in actual or potential harm. And this may involve delayed referral, inadequate monitoring, poor communication, or practicing outside your scope. So when things are put into broad headings, we often just take those wording and go with it and fail to realize that the little things that we do daily amounts to these things. So let's go through some examples which we would consider compromised care in the antenatal period. And let's say, number 1, failure to monitor or assess properly. What could this mean? Well, this could simply mean not checking maternal blood pressure at routine visits. Because you would think, she's looking all right. We don't need to check that. Or, you're just not keeping alert as to what the blood pressures would have been reading from her prior visit to her visit now, right? Another one could be ignoring reports of reduced fetal movement, failing to measure fundal height and arrange growth scans when indicated. The compromised care here would result in missed early detection of serious maternal or fetal complication. Let's look at another one. Failure to refer or escalate. Continuing to manage breech pregnancy without referral. Now we have specialist clinics in Trinidad and Tobago. I'm not sure what each regions offer in the Caribbean. We have private institutions that see pregnant ladies. We promote home births and so on. But if you notice that a pregnancy is breached and you fail to refer to a specialist clinic, that is compromised care. Not referring a patient with gestational diabetes is compromised care. Failing to escalate abnormal lab results is compromised care. And this compromised care here would amount to practicing beyond scope and delayed specialist intervention. Let's look at medication errors. Prescribing iron supplements without checking hemoglobin levels, failing to administer anti-D to a rhesus negative mother, incorrect advice regarding safe medication in pregnancy. That compromised care would result in an increased risk of preventable maternal or fetal harm. Lack of consent, not explaining the risk of home births in a high-risk pregnancy, failing to discuss screening tests. This compromised care leads to a patient being unable to make an autonomous, informed decision and inadequate documentation. Missed records of abnormal findings, failure to document patients' refusal of recommended care results in poor continuity of care and legal vulnerability. So that was the antenatal period. Let's look at the intrapartum period. Failure to monitor fetal and maternal well-being. What does this mean? Simply not performing intermittent auscultation as required, ignoring abnormal CTG tracing, failing to monitor maternal temperatures during prolonged labor. This compromised care results in an increased risk of hypoxic brain injury or maternal sepsis. Delay in escalation. Not calling for support during a difficult shoulder or shoulder dystocia. Delayed transfer from a home delivery where obstructed labor is being suspected, right? Failure to act on signs of uterine rupture. This compromise results in preventable emergency deterioration. Under medical mismanagement, we could look at incorrect oxytocin dosage, failure to administer prophylactic oxytocin after delivery to prevent hemorrhage. In Trinidad and Tobago, our doctors more or less monitor epidural administration. I'm not sure if anywhere in the Caribbean, midwives are charged with the responsibility of monitoring epidural administration. However, if it is in your country, then that too, failure to monitor this administration amounts to compromised care.
Apologies, Miss Robinson. Miss Richardson.
Richardson.
Apologies. Are you able to navigate your slide? Because your slides, they're not moving.
I am sorry.
Thank you.
These wouldn't be on this that I'm speaking about here. Isn't on a slide. It's just it's this discussion, right? So we have covered the antenatal period and the intrapartum period. So let's look at some in the postnatal period. And this could be failure to recognize maternal complications, such as missing signs of postpartum hemorrhage, ignoring symptoms of postpartum hypertension, failing to assess for postpartum depression. And this compromised care would result in delayed treatment of life-threatening or serious conditions. With the newborn, failure to assess newborn properly, not identifying neonatal jaundice, missing signs of neonatal sepsis, failure to monitor weight loss and feeding adequacy. This compromise results in preventable neonatal harm. Poor breastfeeding support, providing incorrect latch guidance, causing feeding failure, not recognizing dehydration in a breastfed infant, and this compromise results in nutritional compromise and may lead to readmission. Inadequate discharge planning or education, not advising on warning signs such as bleeding, fever, reduced feeding. This compromise care results in lack of continuity and delayed help seeking. Document failure, not recording estimated blood loss, failure to document APGAR scores, incomplete handovers to community care providers, and this compromised care results in the break of continuity and defensibility of care. So this brings me to documentation as a legal evidence. Why is it important? Well, in court, documentation is critical. If it is not documented, it is presumed to have not occurred. Medical records serve as evidence of assessment, reasoning, communication, escalation steps. Incomplete documentation signifies a weak legal defense. So in assessing what we look at, in assessing matters, we look at the following: civil liability, which typically involves malpractice, claims for compensation. Criminal liability, this is rare, but may arise in cases of gross negligence. Professional disciplinary action may include suspension, license revocation, or mandatory retraining. These consequences extend beyond financial penalties. They affect careers, reputation, and mental health. So, having said all that I have said so far, I wish to have you seriously note that legal matters do not, and I repeat, do not occur solely by our practice. And what do I mean by that? Well, review of matters would show that legal cases often reveal systematic weakness, such as staffing shortages, lack of equipment, and delayed transfers. While individuals may be named in lawsuits, institutions share responsibility for safe systems. Repeating that again, while individuals may be named in lawsuits, institutions share responsibilities for safe systems. So let's revisit. When looking at maternal outcome, compromised care may result in hemorrhage complications, eclampsia, sepsis, emergency hysterectomy, or maternal death. Each outcome carries clinical, emotional, and legal implications. And for our neonatal outcomes, neonate hypoxic injury may lead to cerebral palsy or developmental delay. These cases often result in high-value compensation claims due to lifelong care needs. So, in my research, I came across something called the 3 delay model. Just a minute. So this model identifies delays in seeking care, reaching care, and receiving adequate care. Midwives have direct influence over delay number 3, the quality and timelessness of care once the patient reaches the facility. So let's consider a woman in prolonged labor. Fetal monitoring is inconsistent. Escalation is delayed due to staffing shortages. The baby is born with hypoxic injury. What must we then ask ourselves in assessing this matter? What do we need to ask? Well, we would need to ask, was there a breach of duty? Was harm foreseeable? Was documentation adequate? And did institutional failures contribute? This illustrates the intersection between individual responsibility and system-level accountability. So then we go to risk mitigation. How do we achieve this? Well, risk mitigation or risk reduction requires action at 3 levels. First, individual level, where continuous professional development, stimulation training, and legal literacy is required. Second, institutional level. At the institutional level, standardized documentation systems, incident reporting mechanism, clear emergency protocols. And third, policy level. At the policy level, strong regulatory oversight and clear scope of practice. The safest practice environment is one that promotes transparency rather than punishment. So, what does this statement mean? Well, the statement means that in a workplace, especially in healthcare, people feel safest when they can openly speak about their mistakes, concerns, or risks without fear of being punished. So let's break it down. Transparency, being open and honest about errors, near misses, problems, or unsafe situations. Punishment, blaming, shaming, or disciplining people automatically when something goes wrong. So simply put, what it is really saying is safe environment is not one where people are scared of getting in trouble. It's one where people can say, I made a mistake. I almost made an error. I think something is unsafe. When people aren't afraid of punishment, they are more likely to report issues early, learn from mistakes, improve systems, and prevent future harm. If punishment is the focus, many people hide mistakes and actually make things more dangerous. For instance, in hospital, punishment culture is a nurse make a mistake, let's say a medication error, and is immediately blamed or disciplined. Others become afraid and they will not report a mistake. This in turn leads to complication. The transparent culture is that the error is reported openly, and a team investigates what went wrong in the system, and procedures are improved to prevent it from happening again. So after saying all of this, in short, safety grows when people feel psychologically safe to be honest and not when they are afraid. I must apologize for this PowerPoint presentation not moving in order with the what is being presented. I apologize for that. So I'll just go to the key takeaways. What are our key takeaways from this session? So simply put and shortly listed, they are Legal accountability is inseparable from clinical excellence. Compromised care affects mothers, newborns, families, professionals, and institutions. Documentation, communication, competence, and system support are our protective tools. In conclusion, I would like to emphasize that strengthening legal awareness and clinical governance in the Caribbean with midwifery practice improves patient safety, protects professional, and strengthens health systems. Ultimately, the most effective strategy to reduce legal and financial risks is to consistently deliver safe, ethical, and evidence-based care. And on this point, my presentation ends. I do hope that the information shared would have been well received. I don't know how much time I have left, so I look to be guided, and if I may be permitted, I don't know if you all will permit me to ask questions just to ascertain whether or not the content was understood.
All right. So thank you so much, Miss Natasha. Thank you so much for that enlightening presentation. Of course, I'm seeing the horns and the hand claps going up and all of that. Just to let you know that we're going to go back to Dr. Curtis, allowing her to finish her presentation. And then, of course, there's a question and answer section that is going to be done by Lady Marcia Rollock. So by then, persons, of course, we had asked you earlier that if you had any questions or comments to place them in the chat so that our Q&A personnel can deal with it so that, yes, Miss Richardson, you'll be able to answer all the questions at the end. And so we thank you once again for such enlightening, very enlightening indeed, presentation. And then we're going to ask Dr. Curtis at this time just to come back and pick up where she left off in her
If
presentation.
I may, I just want to apologize sincerely for the little glitch with the PowerPoint presentation not going in sync with what I was saying. I apologize profusely for that. I could not have done anything to help it.
That was fine.
Apologies accepted. We thank you once again. At this
Okay.
time, Dr. Shirley Curtis to continue and finish her presentation. Dr. Curtis, your time.
Thank you, Madam McNally. I don't even know where I should start. Because
I
I don't
think you were on the slide that was telling us about the antenatal, probably to touch the one before that,
okay, let me see.
which I think you actually ended it though. That was the last one.
No, this one is subsequent. This one?
You were at the screening.
You were at the screening. No, not this. I think you know you had passed this. So go to the screening.
So this is now labor.
No, you weren't there.
The slide that she had up, if I may say,
Uh-huh.
the slide that you asked if this was it, that was the last slide that you
You were
had.
going through the screening and then on to
Just-
This one. This is what you're
This one?
supposed to.
Yeah.
Okay, awesome.
Thank you.
Thank you very much. Are you hearing a feedback?
No, not really. No.
Okay, awesome, because I now turned on 2 devices just to be sure. Okay. So what we were talking about here is the fact that American College of Obstetrics and Gynecology in 2025 have decided that the antenatal visit schedule that we know, the one that's on the screen, is not necessary. That it's too much visits for the client. Sometimes it makes antenatal visit more laborious. It makes the client to look like a defaulter, And actually, we don't need to see the clients this often. Of course, the doctors will say that because they don't do education. But I think the issue is that we have aborted our parent craft classes. So if we institute the parent craft classes, then we can go to less visits, because then we are giving information to the clients via the parent craft classes. What they're saying is that after the first visit and you do your labs, if the patient booked early, you don't need to see that client again until the period of viability, because that period in there is basically education and monitoring growth. So they say you don't have to see them every 4 weeks. That's too much, right? So this is their documented paper in 2025, American College of Obstetrics. So, but this, however your schedule, you have to ensure that the client is aware of it and that they keep that schedule, and that the monitoring is done during that schedule. And I'm glad Ms. Richardson is now finished, because I was listening to her. As you go ahead through those visits, in your risk, documentation is key, and timely referral when any change of status is identified, thus mitigating legal action, right? As it relates to the midwife. All right, so in subsequent visit, we carry on with our skills, and we are testing the clients. We're doing urinalysis, checking those blood pressures against those baselines. Remember, we talked about the baseline. The baseline weight gain is the patient gaining weight in a timely manner, in the way that we would want to, whether less or more. Is the fundal height congruent with the gestational age? These things are important. And so when you look at the American College of Gynecology's paper, then you have to say, well, by the time they reach second trimester, we are already behind the 8 ball if we are not monitoring that client. You see, the obstetricians will tell you one thing, but as midwives, we know that we need to monitor more. Okay, so is it congruent? Checking your fetal heart tones at every visit. The fetal position, Mrs. Richardson talked about identifying the breach and referring in a timely manner, and knowing when to refer. A breach in the first trimester, there's no need to for referral, right? But now if you reach third trimester and that patient is in breach, that is now when you're going to refer that client. Okay, so you have to know when to refer. When does that classification change? When does that risk change as it relates to your practice? All right, because we know that the positions change when the babies have more space. Okay, so your fetal positions, and then education and advice. She talked about giving the right advice to the client and giving timely advice to the client, right? Offering your prenatal vitamins, your iron tablets, and the fetal movement monitoring. Remember we said about listening to the client. Every time when the client comes, you might go through your list of stuff, and then you say, anything you want to discuss with me? And sometimes they'll say, you know what, I don't think this baby moving as it used to. Yes, the baby is moving, but now the mother is picking up on something else. So as midwives, we have to listen to that mother as we go through our subsequent visits. Every visit, you can't make it a rush event. Make that client feel as if what she has to say matters. In our labor management, even if that patient comes in as a low-risk client, your risk assessment still continues, because sometimes the client might not have been at risk all antenatal, but now she has gone post-dates. she's post-mature, that there's a different risk here, right? Maybe the baby wasn't breech, or maybe wasn't diagnosed breech all along, but now she shows up in labor as a breech presentation, or the presentation is now transverse or whatever. So there are different risks in labor, which differs from the risk that you would have identified in the antenatal period, right? So if the head is persistently high and now the patient is going into labor, what are your risks there? If this patient have spontaneous rupture, cord prolapse, and then know not to rupture the membrane if the head is high, because now you put the patient at a different risk, right? All antenatal notes should be available to the labor management team. In the Bahamas, we have what we call the perinatal passport, and if you I remember at the beginning, I asked if any country has its uses the SIP or the perinatal record. So I have here in my hand what we would call the antenatal passport. And we always tell our clients, don't leave home without it. You know, that's what you will tell somebody traveling overseas. You know, you have to travel with your passport. So we always tell them you travel with your passport. So most of the information on the passport is what is in the file. So for whatever reason, you can get your hand on that patient's file. When that patient walks through the door of labor, they present you with their passport, and at least you have most of the basic information of the care that patient would have been given in antenatal clinic, so that it does not delay. Remember, Ms. Richardson talked about delay? Right, so that's a systemic delay if now you can't find the file to see what happened to that client during the antenatal period. What are those baselines? What are those labs? All of those things are in the passport. When the client comes, that information is there. You have all her SDI screening, everything, what treatment she had during the course of the pregnancy, right? And so some of the additional information related to the labor process, now you might have more subjective information going here as it relates to the client, because she has to tell you what was the onset of her contractions, so that you would know when you're moving into prolonged labor. So when was the onset of those contractions? What is the status of her membranes? Did she have a rupture or not? Right? The presence of vaginal bleeding, fetal activity. Has there been any changes in the fetal activity? And I always tell people, no activity is one thing and too much activity is another. Because I always give the example that if you throw somebody in a pool who cannot swim, you will have a whole heap of activity. That is not reassuring. And that's the same thing with a fetus. If a fetus is having a lot of issues, like things like cord around the neck, and that baby is being basically strangulated, you might get a lot of activity, more than you would normally have. That is not necessarily a good sign. So you want to see consistency as it relates to the movement of the fetus. And when you're asking them about fetal activity, it's not if you felt the baby move. Have you seen any changes in activity? Because I tell them, I also say, if you throw a ball in a pool, that ball will move. It will bounce from one side of the pool to the other side of the pool. So that you have patients coming in with stillbirths and you asking them, are you feeling the baby move? They are telling you, yes, ma'am, I'm feeling my baby move. But is the movement different? So a movement of a baby as opposed to a movement of a limb, that baby putting up an elbow, putting out a fist, kicking, that's a different movement. And so you have to sensitize from the antenatal period decline to the difference in movement, right? And so that in and of itself is going to change the risk factor of that client. So fetal activity is important. Of course, then the maternal vital signs are going to give you risk, position, presentation, and now you're going to be now monitoring the contractions. So if you're having tetany, that's signs now for rupture. So when she talked about litigation, and did it happen because you ignored certain symptoms, right? The status of the cervix. All of these things are going to, in labor, give you your risk assessment. Continuing, you have to identify the appropriate risk factor is crucial to the proper management, because if the patient is high risk in labor, patients identified, as high risk in labor account for 20 to 25% of poor pregnancy outcomes. But low risk clients also account for some of those risks as well. They have poor pregnancy outcome. They came in as low risk, but then they have labor risk factors that were not properly identified. So risk pregnancies can have intermittent monitoring. And so you don't have to put the patient on continuous monitoring if the patient is a low risk client. And you're well within your right to do intermittent if the patient proved to be low risk. But if the patient is high risk, now you put yourself up for litigation because you did not do continuous monitoring on a high risk client, right? And now, remember we said now the risk can always change. Okay, so the vital signs, the reactivity of a tracing, reactivity, not a number, not if it's between 110 and 160. Is it reactive? The reactivity of the scan, right? What does the amniotic fluid look like? Do you have meconium? Is there blood in it? Right? For those who do fetal scalp electrode capillary monitoring, what is that pH? Okay, so these are the things that you would look for that will tell you about fetal distress and maternal distress in labor. We also, Mrs. Richardson also talked about the skill of the midwife. All midwives are supposed to be skilled in the monitoring and detection of anomalies in a low risk and high risk clients. Because in the high risk clients, we are working collaboratively with the doctors, particularly in labor, because when they come in, we still have to manage the client. Although the doctor gives oversight to those particular clients. So you have to be able to identify when things are changing and to refer in a timely manner. The midwife should make timely referrals to your obstetric teams. And that's where anticipatory care comes in. You don't necessarily have to wait for the thing to happen. Watch the patterns, watch the changes, and then make your suggestions. Document when you see something that you think needs intervention. Because sometimes you make your suggestions and you're ignored. That's okay. Document it. Because when it comes back now, they can't say that it was you that did not see the signs or ignored the signs. All right, so anticipatory care is very important for the midwife. The midwife should know how to initiate emergencies. Even though we don't manage high risk, we have to initiate emergency care. Whether the patient is eclamptic, whether the patient is shoulder dystocia, you have to know how to manage and initiate the management of those clients. All midwives should maintain certification in advanced life support, ACLS, for adults. And here again, you notice I put documentation at the end of each area, because document, document, document. What did Ms. Richardson say? Not documented? not done. Okay? In the immediate care of the newborn, all midwives should have neonatal resuscitation certification. And if neonatal NRP is not available, in a lot of our countries, we have the HBB available. In the Bahamas, we have started to introduce it into our curriculum, right? So that HBB is a viable option, which is helping babies breathe. But the midwife have to be certified and competent should the pediatrician not be available. And then she has an obligation to ensure that the pediatrician is aware of all high-risk clients in labor, not when the patient delivers. If you have a high-risk client in labor, the pediatrician should be aware when that patient arrives. So they can't go for lunch until they come in and say, so how is that patient doing? How far is she? So they could know how far they can go, if they could go to halfway tree for lunch, or if they have to go to Papine. That's for my Jamaican people. Right? So if they could go to fish fry for the Bahamians, or if they could go over the bridge, can they go east or can they go west? Because now you're dealing with time, right? And so they need to know how close do they need to be for that particular client. Who do they need to have available? What level of staff do I need? So the pediatrician must be aware of these clients. Notwithstanding that a low-risk client can become a high-risk client. That is why the midwife now have to be trained. Because when that low-risk baby mother all of a sudden develops a high-risk infant, the midwife have to initiate the management until pediatric team gets there. The high-risk client have an advantage because the minute that patient becomes fully, you're going to call peds to come, right? So peds already on standby. But when that low-risk client delivers a high-risk infant, the midwife is responsible for initiating that management until the pediatrician gets there. Okay? What's very important in the immediate care of the newborn is keeping that mother informed. All right? I don't know about in the other countries, so I can't say that I don't know, but in a lot of the countries, we rush the patient on the newborn away from the mother. The infant is not resuscitated in the room with the mother. So you rush her away. She never heard a baby cry, right? Or anything. So information is power, and it helps with your litigation, because then they don't feel as if you doctored the information after the fact. You're keeping her informed as you are managing the newborn in problems. Risk assessment continues in that 48-hour period. The first 4 hours are crucial for the mothers and baby as they go through periods of transition. Identification of that baby is important, and document birth injuries and congenital anomalies at birth. Anything that was present at birth needs to be documented and also communicated to the mother, so that 6-8 hours later, peds come back and say, well, the baby has this. You say, no, that's not my baby, because my baby didn't have any of that when this baby was born. Any anomalies, before you take that baby away from the mother, if possible, and definitely before you take that baby away from labor ward, should be identified and documented, and the mother should be informed. Importance, the establishing of feeding, breastfeeding. We know everybody trying to be baby friendly, but if that mother is not breastfeeding that baby, you cannot allow that baby to go hypoglycemic. You cannot allow that baby to become dehydrated. You have to establish feeding before that baby is discharged. Whichever method that that mother chooses to use, although we are going to promote breastfeeding, if that mother says no to breastfeeding, feeding must be established before that mother leaves the institution. Maternal bonding is another thing that should be established, because then we have issues with psychological issues between the bonding of the mother and the baby, postpartum blues, going on to psychosis and depression. Was it identifiable from before that mother left the hospital, right? And ensure that she has the appropriate support. And then, of course, things like making sure that the baby passes urine and bowels open prior to discharge. That's a risk for the baby. And in the maternal transition, we talked about it. It's important to follow up all the conditions in the antenatal period and the intrapartum period that were identified. So for instance, physiologically, if the woman is a rhesus negative, you make sure that that woman gets a rogram before she leaves the hospital, right? You cannot just leave it up to the doctors. That is also your responsibility before discharge to ensure. If the woman was a diabetic, so has she seen the medical team before she was discharged so that her medication can now be readjusted from her pregnancy state to now her post-pregnancy state? Because then she was put on a regime for pregnancy. Now she is now postpartum and you're sending her back out. That medication regime might need to change. Same thing with a patient with seizures. So in seizures, they might have adjusted her medication because of her original medication might have been teratogenic. But now that she's going back out into her postpartum, does her neurological team know that she's now delivered and being discharged, and they can decide how they want to regulate her medication? All of these things are part of what we do as relates to that transition period for the mother and cardiac patients, whatever condition you identify. In the intrapartum period, she had an episiotomy, ensuring that that episiotomy or laceration was actually sutured, looking at it, ensuring that you're not having hematomas, you're not sending the woman home with a hematoma. All of those things, sometimes I remember in a particular instance, and this was not in the Bahamas, in one of my areas of training, this patient, she was screaming. She was screaming in the room. She was an adolescent too, and she was screaming in the room. So I said, "What's going on with that patient?" So they said, "Oh, she had a very bad laceration and episiotomy, and she's screaming with pain." So, well, what do you expect? What does she expect? We told her that it's going to be painful. So I was there with students. So I said, "Oh, assign one of my students to that client for me, please." So they said, "Okay." And they assigned one of the students. So I got the student to go in because I wasn't licensed to go in to the patient unless I was following a student, right? So I said, tell the student, now you have to do a head to toe assessment on the client. And I stood there. And as she went down and I showed her how to do breast assessment and fundal assessment, I said, now check the perineum for me. That was my bottom line. I wanted to see, why was this client hysterical about her perineal pain? And sure enough, there was this huge hematoma. And I just stepped out and I said to the nurse, because in that area they have registered nurses in the postpartum floor. I said, "Step in, please." And she came back in and she said, "Oh my God, that patient had to go to theater for evacuation of that hematoma." So you have to follow through, right, on anything that happened antenatally, or in the intrapartum period before that patient is discharged, right? So that's physiological. And then psychological changes, if the patient is a psychiatric patient, making sure the patient is on their medications. If the patient is showing signs of lack of bonding, distance from the baby, making sure that all of those issues are attended to before. And then the proper education and the support being provided for that patient. But in conclusion, do not forget the human side of management. We want respectful, culturally sensitive care, right? Pain management, involve family members as much as possible, and documentation is time sensitive. All right, so they are my final points. And in order to preserve, protect, and enhance perinatal outcomes, remember that risk is not an event. It is it's ongoing from the first visit up to postpartum follow-up. And these are some of the references. I just want to say that Gabi Obstetrics, I find is an excellent text. It's not by midwives, strangely enough, is doctors, but they tend to deal more with your high-risk clients, whereas your Miles textbook covers a lot of your midwifery issues. Thank you very much.
Thank you so much, Dr. Curtis. Thank you so much for that wonderful presentation. I noticed the hand claps going up and all the emojis going up. Thank you, emojis and all of that. We thank you so much for closing off that part of your presentation for us. The chat is bubbling with discussions. The chat is bubbling with questions. And at this time, our immediate past chair of the Education Committee, that is Mrs. Marcia Rollock. At this time, she's going to do the question and answers right now. So, Ms. Rollock, over to
Thank
you
you.
for question and answers.
Thank you, Petal. Thank you. And I also want to convey my sentiments to the two speakers for two very informative presentations. And looking in the chat, there are lots of questions. So I want to start with Dr. Curtis, since she started off the presentation. There was a question in the chat. Is it standard practice to assess HB before giving iron tablets? Dr. Curtis?
Yes, if you are prescribing ferrous sulfate to the patient, you have to have a reason for prescribing the ferrous sulfate, even though in pregnancy, it's a routine medication. You still should have information on the client's hemoglobin, because it's not a one size fit all. So most patients you can give a ferrous sulfate 200 for them, but there are clients that need more. And so if that patient's hemoglobin was below 10 and you're still giving them ferrous sulfate once a day, that's still malpractice, because you were not even aware that the patient needed more. So you should not just be giving ferrous sulfate just because. You see, giving a multivitamin with iron is one thing. When you add ferrous sulfate, then you should have additional information.
Thank you very much, Dr. Curtis. Question now for Ms. Richardson. Continuing education was not stressed in your presentation. Is this important in preventing adverse events in midwifery practice? Now, I saw you gave a response in the chat, but I think we can all benefit from the answer. Ms. Richardson?
Yes. Yes, I gave a response. Again, I apologize for the glitches with the slides. I do apologize profusely for that. So yes, I did address individual continuous education on the risk reduction. And I said risk reduction requires actions at 3 levels. First, the individual level, where we look at continuous professional development, simulation training, and legal literacy. Second, we looked at institutional levels, standardized documentation system, incident reporting mechanisms, and clear emergency protocols. And thirdly, we looked at policy level, where it was recommended that strong regulatory oversight and clarified scope of practice would definitely serve in risk mitigation.
Thank you, Ms. Richardson.
You're
Dr.
welcome.
Curtis, a next question for you. Dr. Curtis, is it safe for pap smear to be done during pregnancy?
Yes, it is. You would find that most doctors nowadays, and most practitioners, I should say, might leave it for postpartum. But the reality is, if that woman has not had a pap smear in the last 2 years, if she has not had a pap smear in the last 2 years, and you're going into a pregnancy which is high hormonal, it is almost you are sending that patient into a high risk environment if she has an early cervical changes that is not dealt with. So therefore, it is recommended, if the patient has not had a pap smear in the last 2 years, that a pap smear be done in that first trimester of pregnancy.
Thank you, Dr. Curtis, for that answer. For Ms. Richardson.
Let me ask a question. What is the practice in the Caribbean? Anybody have any different practices? Let me put it that way. Anything different? You can put it in the chat. I'm looking at it.
Okay.
Okay, go ahead. I just asked the question, but put it in the chat so we can see.
Right.
So you can move on, Marcia. Thank you.
Okay, so for Ms. Richardson, the question is, what is the evidence-based practice pertaining to all antenatal patients and their documentation?
I'm sorry, I don't understand. What was the question?
Well, this is the question. I tried to as it was written, I'm asking it. What is the evidence-based practice pertaining to all antenatal patients and their documentation?
If I understand clearly what the question is trying to ask, evidence-based practice, I mean, it's guiding principles that would let us know that all care should be documented. If anything is left undocumented, then it is presumed that it was not done. And documentation remains the most important standing point to carry forth a legal matter. If we don't have that in place, then we don't have a legal matter to fight on. Other than that, I hope I understood and answered the question. It is.
Can I add to it?
Sure, Dr. Curtis.
Yeah. So, in addition to what Mrs. Richardson said, evidence-based, so that now you're dealing with your protocols and what evidence your protocols are based on, right? So, if in your particular jurisdiction, you're using the SIP form, the passport, as relates to the documentation, you might have documented it someplace else, but we are using the SIP form, and you did not properly document your findings in the SIP form. That means you did not put it where it's supposed to be for other persons to act on it.
Yeah, yes, so he hooky for in a blue. At least it's how tall it is.
Melissa, thank you. Okay, so yes, so when you talk about evidence-based, you have to document, you have to document. Remember the last thing I said? Documentation is time sensitive. So when you document, if you're documenting and you're going back last week, something that you were supposed to have written, um, you're doing it next week when you should have written it last week. That's when you're talking about evidence-based now. It has to be done when it's supposed to be done, what is supposed to be done. All of that is a part of it.
Okay, thank you, Dr. Curtis. That was a question for Nita. Right, so we go back to Dr. Curtis. I've lost track. Who was it? There are some comments on the same pap smear, but you said to comment in the chat. So if you check that, you can answer some of the questions there. But the other
Okay.
question I wanted to ask you, Dr. Curtis, somebody asked, would the practice of drills and skills for staff in the obstetric department help to prevent or lower the risk of adverse events?
Definitely. And I did not go through that because I know that Mrs. Richardson was going to deal with the legal, and I didn't want to try to move too much, but definitely certification and recertification of skills. I talked about a few of them as it relates to resuscitation, but for all skill sets, a midwife, because you're being registered in your various areas as independent for the most part or codependent professionals, you must show yourself to be worthy of that certification. And so doing drills, attending webinars, going to workshops, getting your credit hours in is vital, and skill set. Skill, as it's a very hands-on profession. So those skills drills are vital to mitigating loss and injury.
Thank you, Dr. Curtis. And in that same vein, this is a question for Ms. Richardson. Is it appropriate for a client to sue a midwife?
It is appropriate for a client to sue, well, a midwife can be sued, whether practicing in privately or within the hospital settings. But there needs to be proof of negligence, and there needs to be a clear causal link between her actions and the alleged harm. So, in what I would say is that yes, a midwife can be sued for her practice. Just looking back at the slides here to guide the answer. To successfully sue, the client must prove that the duty of care existed, right? This means that the midwife owed the patient a professional care and there was a breach of that duty in that the midwife failed to meet the accepted professional standards, and causation must be proved as well. The failure directly caused harm and damages suffered by the patient is measurable because of the causation, right? So a poor outcome alone is not enough to prove negligence. As presented before, there must be a duty of care owed, and that duty was breached. The causation would result in damage caused. If the midwife is working in a public hospital, like in Trinidad and Tobago, we have the RHAs, right? So the RHAs may be sued vicariously and the midwife may also be named in the lawsuit. I hope
Okay.
this answers.
Thank you very much, Ms. Richardson. I think that is a very good answer. And
Okay.
one other question to you, somebody asked, and I'm not sure if you could answer this question, but can a midwife with her own practice in Jamaica give a patient sick leave?
I'm not familiar with what exists legally with regards to sick leave in Jamaica, but I am almost certain that medical doctors are the ones who issues medical certificates. So unless that midwife is also a medical doctor, I don't think that she could issue any sick leave. I mean, based on our practice in Trinidad and Tobago, sick leave is only given by a medical officer.
Right. Well, thank you. I hope that answers the person's question, because I'm not sure in Jamaica with the nurse practitioner if that is under their scope of practice.
Well, I would
I'm
need to
not
be
sure.
guided as to that as well.
Anybody from Jamaica could enlighten us?
Nurse practitioners can give sick leave.
They can.
If they
Okay.
are registered as a nurse practitioner, they can give
Right.
sick leave.
Okay.
Yeah.
All right. So that would answer the person's question. And okay, so just one, well, of course, all the comments that the presentations were very interesting and all that we saw in the chat. And then somebody commented, and I don't know if we have time to discuss this. Somebody commented that the patients should get their antenatal records from the get-go, because you just never know at times. A lot of miscarriages, threaten abortion, threaten miscarriages, etc. So I don't know if the
I can,
person who wrote this, the practice
yeah.
is
I think
different
it
for them.
varies, Marcia. It varies from country to country. For instance, even though our patients have their perinatal cards, right? But every week, every antenatal clinic, the 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 records are moved from the hospital to the clinic, and at the end of clinic day, it's moved back from the clinic to the hospital. That has its pluses and its minuses, and that's just our system. Even though the patient has the perinatal record, this is the let me see. Did I have it here? So the perinatal record will look like this, but the passport looks like this. So this is something that the patient carries with her at all times. But we don't give the patient this to carry unless we are sending them for immediate admission from clinic directly to hospital. We will wrap that up and send it and say, okay, present this to labor ward when you go, because the reality is this wouldn't reach back to labor ward until end of day, and I want you to go now. So you carry it, right? But other than that, if something happens to the patient before the record reaches back to labor ward, that is why that perinatal passport is so important. So we don't allow the patient to walk around with their records every day. Only the passport they carry, and that's just institutional to the Bahamas. Other countries might have a different policy.
All right. Thank you
Yeah.
for that, Dr. Curtis, because I know in Trinidad and the community, I give them a copy of whatever is done, but for them, as they go to clinic every time they visit the clinic, they get a copy of what was done to carry with them. But because our system is different, that they
It's
may,
different,
yeah,
yes.
they may end up in hospital, or so that when they go in hospital, they will have the community record on them still to be followed.
So it varies, and right now we are moving towards computerizing our system. So so that the doctors from hospital can now log in. So that's a slow movement, but we are trying to computerize our system so that there's direct access. Right now we have access to the labs so that you can actually click onto the lab and you can see the results of all the labs that the clients had. So we have the lab access. Now we are moving to computerize our perinatal records as well.
Okay.
So particularly for countries like the Bahamas, which is an archipelago of islands, and I think countries like Guyana, where you have patients that may be coming from far, I think that type of system would be move well towards mitigating issues as it relates to patient information.
Okay,
So,
and I see
permit
that
me to speak.
we have, yes, somebody had a question, Chansley.
Hi, it's just in relation to how our antenatal or prenatal clinics are done in Guyana. I'm from Guyana.
Okay, good.
Yeah, so here in Guyana, we have both the take home and the clinic record the
Yes.
same. So what was done at clinic would be on the big card that would remain at the facility, while this take home card would have the information that's on the big card.
Yes, that's
And
the same system that we have.
however, as it relates to labor and delivery, they will just walk with a take home card. And we will have to clerk up a new chart at the hospital for the labor and delivery because it's difficult to have the big card being transported like you were
Transferred.
saying. Yes.
Right. Agreed.
So that's the reason why we would have that extra record at the hospital settings. So the small card have all the detailed information from clinic. However, that will be transferred during labor and delivery if we can photocopy what they did and put into the big card at the hospital setting. If we cannot, we then transcribe that information if we do have the time and the machines are not functioning to photocopy.
Okay.
Right.
Thanks
So that
very
too
much.
is another challenge.
Thanks a
Is
lot.
work.
It's a lot of work. That's a lot of
thanks.
work.
Yeah.
Thanks a
So
lot,
It
Chansley,
that's
is.
for your
why
response.
I was saying that places like Guyana would benefit from a computerized system.
So we're working on that, but that's a turtle phase.
Yes. So
Right.
us too. Don't worry.
So
Don't feel
thanks a
bad.
lot for your comments, Chansley, and for letting us know
You're
what
welcome.
happens in your area. Yeah.
Thank you. And
So I
Marcia,
think
just
there are lots of different comments and so in the chat. And I want to
just
thank
say
the
just
presenter
just to
for
say, Marcia, sorry that the evaluation link has been posted.
right,
So we
as
just
we
want persons
discussed.
to
Yeah.
right.
So there was a comment that coming out of all the discussion and from both presenters that there needs to be an integrated system and continuity of care for successful collaboration of care. When this is not present, there are delays and fragmented care, as we are all aware and came out in the both presenters' presentations. So I want to thank you all for your comments and your questions. And as Petal said, the evaluation, the link for the evaluation form is in the chat so that you can fill out the form before you come off the platform. Back to you, Petal.
Hey, thank you so much, everyone, for participating tonight. Please remember that you, as Mrs. Rollock said a while ago, Marcia said, that the evaluation form is necessary if it is that you need your CME hours. Once again, on behalf of Caribbean Regional Midwives Association, we want to say a big thank you to all 520 odd, I noticed at one point, persons who came out tonight to be a part of this presentation. We want to say thank you again to our presenters, as Marcia would have said earlier, Dr. Shirley Curtis and Mrs. Richardson. We thank you so much for taking time out of your busy schedule to make this presentation available to us. And we thank you all participants for being here and for participating in our presentation. We encourage you, midwives, to continue to go out there and make your mark. And this, of course, was a well-needed refresher course. All right. And we thank you for your comments. And we look forward to seeing you all at the next webinar. So on behalf of our president, I'm not sure if our president has any last words. Madam P, do you have any last words?
Here. Good night again, everyone. It's been an eventful night full of conversations, and we had our team on, everyone was in tune right to the end of the presentation. Dr. Curtis, thank you so much for your knowledge, for your time, for sharing, and I know we all learned. Ms. Richardson, thank you so much. It gave insight, and I am sure we're all going back to practice safely so that we don't end up in court. So I'd like to extend a big thank you to everyone, to the team, to the education team of CRMA, who really came out to put this together. I thank you. And thank you so much, Madam Chair, and thank you for everyone that participated tonight. Over back to you.
Thank you, everyone, and God bless you. Have a wonderful night. The evaluation link. I'm seeing somebody ask to share evaluation link. You want us to share it again?
It was just shared again.
All right, it was just shared again.
Petal, did we do roll call? Do we know what countries are on tonight?
I'm not sure
Did
if
you
we
put
have
it in the chat? Did they?
Yes, it's in the chat, and
Okay.
we had
No,
gone
just for
through.
our
Yes, when you
records.
dropped off. When you had dropped off, we were doing that.
Okay, awesome.
Not seeing the form.
And good night to everyone.
I just posted it again. I'll post it again. Check the
And
chat.
I just posted
there
it
it is
again
again.
too.
There it is
There it is
again.
again.
Stop recording, please. Or did we record at all?
Yes, we
Yeah.
did.
Yes, we did record.
Okay, stop recording then.